All right, Dr. We are live.
Great.
Good afternoon. Welcome to Bariatric Friday. This is our weekly Bariatric Friday event. So we discuss morbid obesity challenges and also try to support our patients who are going through the process before and after surgery. And I have one of our experts in the area as one of the best surgeons in the United States, one of the best bariatric surgeons in the United States, Dr. Isaias Irgau with me. Dr. Irgau, how are you doing?
I'm doing well, Kemal. Thank you for having me. I'm excited again for another session of Bariatric Friday.
So this event is becoming more and more important for our patients. We do actually, we do get a lot of feedbacks, and that's one of the reasons that we are actually doing this again and again. You know, one of the important things is for us to be able to bring the knowledge and experience and blend it in with the guidelines of the process. Like, not everyone is able to actually maybe understand the challenges that patients are going through, right? So, and I do believe that we are lucky to have you on a regular weekly event and be available. Because if I was doing this just as a practice administrator, CEO, healthcare executive, the credibility is going to be only so much because there's always the business part of it. But the surgeon whose expertise is bariatric morbid obesity is available, and then we have like a fresh session every week. So then in some cases we may repeat the same topics. It is necessary to do that, and thank you for being available again. So today we are going to discuss the care coordination aspect. So the care coordination aspect comes from the main preparation process, the screening process, and getting the patient ready, and also manage the multidisciplinary approach. In time, there was this need of care coordination. Now, Dr. Irgau, I've been working with you for almost 20 years. And in this time, the care coordination evolved to a point where it used to be at certain frequency before. Now it's a daily event done by nurses. So if you can give us the background of the care coordination and why it's important for our patients and what they should expect from the care coordinator, and then I'll also help you with some of the from different angles. I will also put a couple of
course, yeah, thank you, Kemal. So essentially, bariatric surgery is currently the most effective treatment we have for morbid obesity and also for diseases associated with morbid obesity. As a surgical procedure, bariatric surgery has been around for a long time. Currently, there is widespread acceptance and support of bariatric surgery by all healthcare professionals, right? And this includes primary care doctors. It includes specialists like fertility doctors, orthopedic surgeons, neurosurgeons, who routinely would now, without any issues, really refer their patients for bariatric surgery when they see that morbid obesity is an impediment to the health of that person. The reason bariatric surgery has received this enormous acceptance within the medical community, in my view, Kemal, is twofold. One is that bariatric surgery has become a very safe procedure in the way it is undertaken at centers of excellence like ours at the American Surgery Center. And the next reason is because of the predictably good outcomes that are duplicated time and time again with patients who undergo bariatric surgery, and resulting in excellent weight loss, improvement in health-related problems. Right. So for these two reasons, now there is a lot of acceptance and push by doctors really to recommend bariatric surgery to their patients. And it is probably not, it's reasonable for us to say that the reason we have these two good aspects of bariatric surgery is really based on good care coordination in the background, right? In other words, care coordination is really the collection and ongoing meetings and discussions of a multidisciplinary team around the needs of the bariatric patient with the help of a database like the one we have at the American Surgery Center, the one that we continuously improve and deepen. As you know, you were the one actually who started that for us, Kemal. That is really the bottom line of care coordination. And in other words, what happens is that after a patient is seen by the surgeon, and they are referred to be evaluated by a number of specialists, including heart doctors, maybe lung doctors, maybe hematologists, to add their inputs in the preparation of that patient. But at the same time, that patient is also referred for what we call the bariatric preparation, which includes seeing a nutritionist on a number of occasions, seeing a psychologist, maybe having different medical tests. That type of arrangement requires close coordination in a timely fashion, right? And that's what the care coordinator process does, right? So it is the team that meets, and in our case, what makes us unique really, Kemal, is that these meetings occur actually on a daily basis. The vast majority of programs, you would see them meeting maybe every 2 weeks, if not every month at best, right? Our teams actually meet every day, which means that discussions on where the patient is, what support the patient needs, happen maybe 20 times, 25 times for a single patient throughout the process. This gives enormous support and guidance to the patient as they are going through the process.
So most people, well, I mean, I don't want to say most people don't understand. So that's a bad sentence structure. So people probably have some understanding, but a lot of people don't have a really good understanding. So I'm going to read something from our support group that's posted yesterday. If a year ago you told me I would from a size 18 to size 8, but I'm just reading it the way it is, size 18 to size 8, I wouldn't have believed you. If you would have told me you would be able to see my jawline, I would probably laugh in your face. If you told me I would be up at 5:30 every morning, work out, and logging my meals all day, I would probably wouldn't have passed out from laughter. So from size 18 to size 8, and maybe the shape, the BMIs, all those. Let's say that those are all details, and some people have their own description. But the person is saying that getting up at 5:30 and working out and logging my meals, right? So this, number one, it's a huge achievement because one of the reasons that we have this type of support, and you may remember this morning I shared with you, one of the patients in the case conference finished everything. So it's almost like 16, 17 checkpoints. Yeah. And then getting ready for surgery, and he changed his mind, even with all the support, right? So we see those less and less anymore, but bringing people to a point that they can actually even have the surgery is a major challenge for them and for us, because some practices, they don't have the same means that we have, or same maybe understanding that we have. So that's why the care coordination, to bring that patient into this person, the one, your patient is a 25-year-old guy, and BMI 47.
Mm-hmm.
You finish everything and then you stop, like you change your mind. So I felt like it was a failure for me, for us, like care coordination side, because what could I have done differently? So maybe, but I know from another, another part of the issues, I know that that patient probably was dealing with a lot of social stigma, right? So a lot of people were kind of doubting him, and then someone was able to get through him, because surgery can be scary for many people.
Right.
Looking at these types of, like, going from size 18 to 8, and when person is like, they're posting their own story, and we're not telling them to post this. There's no, in fact, this is a private group. I'm just telling you what they are actually sharing, but I'm not giving any details on the person. But this is amazing. Yeah. So that's why we have this care coordination with the nurses, and also make the patient understand, one of the issues that we always have in the past, if you remember, there was a bigger problem where, why do I have to do this diet? Like 2 weeks, or in some cases 3 weeks. And our nurse care managers, care coordinators are right now, they're better at explaining that than many of the other people in the practice, because that's what they do, and they give that information in a better way. They have a better line of communication with the patient. In some cases, it's not limited with the office visits, so they are available. So from the care coordination point, I think that's really important.
Absolutely. So essentially, to connect the two issues of the safety and good outcomes of bariatric surgery with what we do at the care coordination level, we have to see what it entails to prepare for bariatric surgery, right? Well, one is that person has to be prepared so they can go through the surgery safely. So their medical issues have to be addressed, looked into, and a specialist may need to be involved to do that, right? That's one aspect of the safety. But the other one, which is the important issue, is what you just mentioned about the example of the posting of the story on the support group, right? What did that person mention? Well, they mentioned the fact that their size now is a lot smaller, when you could say, well, the surgery does that predictably. But the surgery does not make a person get up at 5:30 and work out, right, Kemal? So what made the person do that is that preparation, right? A multidisciplinary preparation, which emphasizes the fact that the surgery is a powerful tool, but it needs a partnership also in terms of a committed person to do things in a sustainable fashion in the long term, so that results are also sustained in the long term. And that is what is appealing to all these medical practitioners when they recommend bariatric surgery to their patients right now. They're saying not only the surgery is safe, that it has been shown time and time again, but the results are also predictably good, but also sustainable in the long term. Well, to be able to do that, we have to get the patient that comes at the consultation time a list of things that they have to do. You have to go see a cardiologist. You have to do this test. You have to do this X-ray. You have to do endoscopy. You have to see a nutritionist. Well, if I gave that list to the patient and then let them be there in the world by themselves, Kemal, how many patients would really have the ability to navigate the system and do this in a predictable way? I would suggest that maybe a minority of the patients would be able to do that, so that the patients who actually end up having surgery would be a very small fraction of the ones who approach us, requesting surgery. What makes the difference here is we have a system that helps the patient navigate the system, not only once when they are in the office, but in an ongoing fashion, right? And that team, to be able to accomplish this, has to relook at the process time and time again on a daily basis, right? But to do that, it also needs to have a documentation that is dynamic. And that's what the database provides us as well, right? You could have a care coordinator, for instance, that has been with us for a year or so, but then for whatever reason, they may change jobs, they may change places, and they may not be with us, right? Another care coordinator that we have trained appropriately can pick up from there and run with it because the database is alive. That is what makes a big difference in my view. So not only we are able to help our patients navigate this intricate system that is necessary for them to prepare for the surgery safely, but also we're able to educate them, we're able to take them where is needed for them to be prepared for the aftermath of the surgeries or for them to stay healthy.
So in our system, just to kind of like make sure that patients understand why we have a topic for case conference is because our care coordinators, they interact with the patients even more than anyone else in the system throughout that. So that's the go-to person. As you were explaining earlier, with all the different clearances that we need to get from the from different specialties, keeping up with those appointments. Just to give an example, like they get a cardiology clearance, but it doesn't happen with one appointment. It happens with cardiology clearance with either echo or stress test. So that's two interactions. So in order to determine whether or not they need pulmonary clearance, then we need to do HSD. So that's first step. Then HSD goes into maybe in-lab study, and then they need to get their CPAP, and then PFT and an X-ray. Then they need to get a pulmonary clearance based on their home sleep test score. So then they get the EGD. Well, the EGD, if it's not negative based on the outcome, then we need to decide if we are going to treat the H. pylori or if we are going to change the type of surgery because they have reflux and they have Barrett and they cannot have the surgery like the gastric sleeve, but they can have gastric bypass. So the nutrition, the tree nutrition is now most the standards, even for Medicaid. That was also a good, important step from Medicaid. This is state of Delaware Medicaid, where they went from 6 to 3 nutrition requirements.
It's good. It's good. Yeah.
Help those patients. And I personally believe that those patients were struggling the most because they have to keep up with the 6 nutrition classes. 6 consecutive months, which at some point, like 6 months, you have to do something. It's like 3 more months, you are having a baby almost, right? So like, it's just too long. So then all these things, the psych clearance, then the blood work needs to be in the last 6 months, and if there's anything that's abnormal, it needs to be addressed. So, well, you don't have to worry about any of those because you have a designated, almost like a personal assistant in a way. So you have a care coordinator who's a nurse and who's specialized in this. So it's not like some 800 number that we are calling and getting someone from other parts of the world. So these are specialized in bariatrics. So I'm hoping that that would make it easier for most of our patients. I know it does, but maybe knowing and understanding why we are doing it, it's going to probably help their compliance, and also if they didn't want to do it because it's too overwhelming, then they know that there's someone who's going to help them with the process.
Yeah, I mean, understanding this from the patient's perspective is very important, Kemal. As you know, and as we've said many times, most patients come to the realization that bariatric surgery is necessary after a prolonged time of really thinking about it. In fact, when they first hear about bariatric surgery, most patients reject the idea as something that is not necessary for them. They feel that they have the tools necessary to be able to do it by themselves. But again, they fail time and time again. And then at some point, it sinks, on them that really this is important for them to do, particularly when they start struggling with major comorbidities like type 2 diabetes, high blood pressure, or sleep apnea. But then when they decide that bariatric surgery is the treatment for them, they want it done immediately, right? That's human nature, right? You identify a solution and you want that solution as soon as possible because you want to get rid of the problem that you have. Well, bariatric surgery does not work that way. You come and you have the consultation, but there is a prolonged period of preparation. But that's not out of the whim of the program that there is this preparation. This preparation is an integral part of the success of bariatric surgery in terms of safety of the process and the surgery itself, but also in terms of being equipped for long-term success, right? I mean, I had a patient I saw yesterday, Kemal, who is preparing for bariatric surgery, but that patient was supposed to have upper endoscopy, which we call EGD, and the bariatric coordinator actually alerted us that that EGD should not be done at that time, and we have to reschedule the patient. The patient did not understand exactly what that rescheduling was happening, and the bariatric coordinator rightly advised the patient that that discussion needs to happen between myself and the patient. So the patient came in saying, hey, I was supposed to have endoscopy, that was canceled. Instead, they scheduled me to see you. Well, that process of stopping the EGD, getting the patient scheduled with me by itself requires tremendous coordination. And unless you have a system that is really flexible enough to identify this and undertake it, it would not happen very easily. Regardless, the patient came to see me, and when I looked into the records, what happened was the patient actually had an echocardiogram, which is a test of the heart that we routinely order, right? That echocardiogram demonstrated that there was severe weakness of the heart that would have been a potential problem the patient to even undergo endoscopy without seeing the cardiologist first. So it was correct for that process to happen, right? So the system reacted excellently in that situation. The care coordination worked brilliantly, and that patient came in a timely fashion to my office. I was able to discuss with them what the issues are, what the upcoming tests need to be, and how we need to proceed. And that was, I was able to do that, right? If I was working as a surgeon by myself with my office, Kemal, just how would I be able to coordinate such an intricate process and still maintain highest level of quality with our patients, right? So really the backbone of our process is the care coordination. And you and I have recognized this a while back, Kemal, and that's why we have insisted on having a very, very good system in place.
Absolutely. The way that I see these, there's a challenge. We see a lot of barriers from the patient standpoint. And then our job, the program is we were able to create a system in place that we can remove all those barriers for you, so then you don't have to deal with them, right? So this is the care coordination piece. So because it's a lot, it's a big undertaking. So don't feel overwhelmed. Sign up, see your surgeon, get to the first consult. There is so much, like, to a point, some patients, they say, well, we're okay, you don't have to call us every week. It happens, but there's so much support there. And then not just like trying to tell you what to do, but we are doing certain things on your behalf, getting your appointments, helping with your appointments. You were a little bit late in the beginning of the case conference this morning. So there was a patient who had transportation issue. So during the case conference, I called her. So because surgery is next week. So then she was going to drop her HSD SD card. And she couldn't find the pulmonary office. So I asked her to go to our downtown office at United Medical. And then we had someone take that and then drop it off to the pulmonologist's office. How is that possible? Right? So how do we actually know, or why do we do it? Is because we know that there is a support that's needed. It would be incredibly so irresponsible for us to let that patient fail because they didn't turn their HSD. And so then we put all the efforts out there, and then there's 7-8 people discussing this issue, and then we try to take care of it. So that's how it works. And there's no reason to be afraid of the process because there's a very strong team now. I'm reading another support group. This is a male patient, had surgery on 3/9. So this is 3 months ago. And then this is posted 2.5 months after. Pen weight size 58 to 46.
Right.
And this is not a dream. So, I mean, we are reading random outcomes, and we know that this is the most efficient way to fight morbid obesity, take care of the problem, and we are here for you. So, from the surgeons to the every level of the office and facility, everyone, our expertise is bariatric. So, hopefully we can help more patients, and we'll be back next week. Dr. Irgau, thank you so much for joining me.
Thank you, Kemal.
Have a great weekend. See you soon.
Have a nice weekend.